This is how antidepressants help chronic pain, what their limitations are, and what natural alternatives we have for them. Remember that nerves only fire at one intensity, and that's 100% all the time. Therefore, things like stubbing your toe should feel the exact same to your brain as bumping your elbow, but they don't. And that's because of a mechanism called descending inhibition. So anytime that a pain signal is traveling up your spinal cord has to determine how much of that pain signal needs to get all the way through to your brain to be processed as pain. So if you bump your elbow, the brain's like, you know what, that wasn't that bad. Send down a whole lot of signals to block this from getting up so that only a little bit gets to your brain. But when you stub your toe, your brain's like, your spinal cord's like, you know what, that was pretty painful. Allow even more signal to get through to your brain so that we feel more pain. What helps determine how much descending inhibition your spinal cord is going to produce are two very important neurotransmitters in serotonin and norepinephrine. So if we were going to take a cross section of our spinal cord, it would look something like this. Serotonin and norepinephrine bind to receptors in the dorsal horns of your spinal cord and produce that descending inhibition. The more descending inhibition we have, the more of a metaphorical wall or gate gets put up and the less amount of pain signal can make it through to your brain. Now, this process is known as central sensitization, where literally your central nervous system is becoming sensitized to pain, and therefore we lose that wall or that gate. We lose this descending inhibition, and more pain signal is able to get through to your brain. You experience pain to things that you shouldn't be, or more intensely to things that shouldn't be causing a lot of pain. And this is just a hallmark of all chronic pain conditions. Now, there are three different classes of antidepressive medications that can help with chronic pain. The first being SSRIs, selective serotonin reuptake inhibitors, SNRIs, serotonin norepinephrine reuptake inhibitors, and tricyclic antidepressants that help with both serotonin and norepinephrine. So these two tend to be more effective for chronic pain because it's serotonin and norepinephrine that we're helping to preserve. But that's the thing, is we're only preserving the serotonin and norepinephrine. We're not helping to make more. So if this is the direction of our nerve transduction, our presynaptic nerve tries to send serotonin and norepinephrine to the second nerve to help facilitate that descending inhibition. At a certain point, all the serotonin and norepinephrine get built up in this synaptic cleft. The presynaptic nerve tries to take that serotonin norepinephrine back, which means that there's less for the postsynaptic nerve. SSRIs, SNRIs, tricyclic antidepressants, their job is to prevent this reuptake so that serotonin and norepinephrine sit in the synaptic cleft longer so that the postsynaptic nerve can take more of it up and help increase that descending inhibition. It's a good mechanism, but if we're not producing enough serotonin and norepinephrine to begin with, what we're preserving here is going to be minimal. We need to help make more serotonin and norepinephrine to help fight chronic pain. So the alternative to antidepressive medications is not to preserve what little serotonin and norepinephrine we have, but to make more of it. So to make serotonin, we start with the amino acid tryptophan, adding cofactors such as iron, magnesium, calcium, B6, B9, vitamin C, more B6, zinc, and more magnesium, and we get more serotonin. But what a lot of people don't understand is serotonin makes melatonin. So if you're suffering from chronic pain and also have sleep disturbances, hopefully now you're starting to connect the dots. If we can make more serotonin, we can make more melatonin and hopefully help you sleep a little bit better. To make more norepinephrine, we start with the amino acid tyrosine, adding cofactors iron, B6, and vitamin C, and voila. But along the way, we also create dopamine, which is another wonderful neurotransmitter for chronic pain. It's your feel-good neurotransmitter, reward neurotransmitter, but also helps with that descending inhibition pathway. So we're killing two birds with one stone here. So you can supplement with all this stuff individually, or we can just start with consuming more protein, especially from animal sources that have a more robust and complete amino acid profile. This is how anxiolytics can help your chronic pain, what their limitations are, and what natural alternatives we have to them. So when you perceive a threat, whether physical or emotional, real or not, you activate the amygdala in your brain. It's one of the fear centers and one of the 44 regions associated with chronic pain. That increases your sympathetic nervous system, which means that you're going to increase muscle tension and your sensitivity to pain. This is creating vigilance so that you can deal with whatever that threat may be. Benzodiazepines and their cousins help increase the inhibitory neurotransmitter GABA, which helps improve descending inhibition. Now, think of descending inhibition like a war between two nations, the one nation being pain and the other anti-pain. So if we have our troops in GABA here and our troops in pain here, they're going to attack each other, and whoever has the most troops at the end wins. So if we have more GABA anti-pain troops, we're not going to feel the pain. But if we have a whole lot more of the pain troops, then they break that barrier, get to your brain, and now you experience pain. The alternatives to anxiolytics are to make more GABA and to balance our autonomic nervous system. To make more GABA, we start with the amino acid glutamine, which is also fantastic for your gut health and crucial for any successful chronic pain treatment plan. So 2 birds with 1 stone. Glutamine gets converted into glutamate, which unfortunately is an excitatory neurotransmitter, so we don't want that sitting around for too long. To get that converted into GABA, we need an enzyme called glutamic acid decarboxylase, which unfortunately gets destroyed by gluten. So just another reason why a gluten-free diet is almost necessary for all chronic pain conditions. Balancing your autonomic nervous system is a task. There's a lot of things that we can do, but it takes time and effort. In the office, we utilize constitutional hydrotherapies, which is a form of contrast therapy that's very effective. Otherwise, things like meditation, yoga, tai chi, breath work, and I get it. I get annoyed when these are the proposed suggestions as well. But they are the proposed suggestions because the scientific literature on them is very conclusive. They work. This is how JAK inhibitors can help your chronic pain, what their limitations are, and the natural alternatives we have to them. When a cytokine attaches itself to a receptor on your cell membrane, it activates a family of enzymes called Janus kinase, or JAK. JAK then puts a phosphate group onto a protein called STAT, hence why a JAK inhibitor is sometimes called a JAK-STAT inhibitor. That STAT protein then goes to the nucleus to either turn on genes that create more inflammation or help fight inflammation. Whether the genes that we're turning on or off are pro-inflammatory or anti-inflammatory have to do with whether that initial cytokine was pro-inflammatory or anti-inflammatory. A JAK inhibitor medication just puts a wall right here between JAK and STAT so that we cannot turn on any pro-inflammatory genes, which seems like a great idea, but I think you're starting to see the problem here. One, this medication does not do anything about the production of this pro-inflammatory cytokine. Those are still forming on their own and are creating inflammation on their own. But if we put up this wall here, that also means that we cannot create any anti-inflammatory, we cannot turn on any anti-inflammatory genes, which means the inflammation that's sitting around, we're not going to be able to get rid of. Not to mention that we're just suppressing your immune system, which is never a good idea. So now we're increasing the risk of infections. We actually increase the risk of heart attacks and blood clots. And we also slightly elevate your risk of contracting certain cancers, such as lymphoma and non-melanoma skin cancers. So the alternative is to focus on treating the epigenetics that would otherwise be turning these pro and anti-inflammatory genes on and off. And we do so largely through nutrition. We treat gut permeability, chronic infections, sleep regulation, blood sugar stability, looking at environmental triggers, stress, treating your autonomic nervous system dysregulation. These are all things that we've been talking about in past videos. Go back, give them a watch, and connect the dots yourself. This is how CGRP inhibitors can help your chronic pain, mainly migraines, what their limitations are, and what natural alternatives we have to them. So the process starts with your unique migraine trigger, which could be a food sensitivity, an environmental exposure, stress, hormone imbalance, what have you. That activates your trigeminal nerve, which is cranial nerve 5. It wraps around your head and your face. So that trigger generates an action potential and that nerve fires. Remember, nerves don't fire for no reason. They need an input. Once that trigeminal nerve is activated, it releases inflammatory molecules, mainly calcitonin gene-related peptide, or CGRP. CGRP then binds to your blood vessels and dilates them. When those blood vessels dilate, you get more inflammatory cytokines to your brain, which increases neuroinflammation. That increases pain and future sensitivity to pain as well. That's right, migraines are largely an inflammatory event, and that's where we need to focus our treatments. CGRP inhibitors act by putting a wall right there. So we actually decrease the release of CGRP, but also the binding to the CGRP receptor on the blood vessel itself, preventing the rest of the cascade from happening. Now, these medications can reduce frequency and intensity for some people if your problem is excessive CGRP release. But keep in mind, this is just one mechanism of migraines. Now, the alternative is not just about avoiding your migraine triggers because a lot of them cannot be avoided, but rather we need to stabilize the systems that aren't appropriately handling those triggers. So if it's a food sensitivity, we need to work on gut health, et cetera, et cetera. But we also do have natural CGRP inhibitors in CoQ10, the herb butterbur, magnesium, and curcumin. They're not as potent as the medication, but as part of a greater treatment plan for your migraines, they can help reduce frequency and intensity.